Hi, everyone. I apologize for the late start, but we are here and ready to go. I'm just going to give folks a minute to join. While we wait, feel free to use the chat to say hello to your fellow attendees and let us know where you're from. I'll wait just a couple more seconds and then we'll get started. Okay, I think we're good. Hello, everyone, and welcome. Thank you for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session, Healthy Smiles, Airways, and Sleep, Orthodontic and Pulmonary Considerations in Connective Tissue Conditions. I'm Lauren May, Senior VP of Research. My colleague, Dr. Christy Langford, the Marfan Foundation's Development Manager, is behind the scenes helping to keep us on track today. This session is being recorded. Before we begin, please use Zoom's Q&A feature to submit questions throughout the presentation. You don't have to wait until the talks are over if something comes to mind. We'll answer as many as possible during the Q&A session at the end. The chat is available for attendee discussion and comments, but questions posted there are likely to be missed, so please put the questions in the Q&A tab. It is my pleasure to introduce our speakers for this session. Dr. Sylvia Frazier Bowers is the Richard L. and Nancy M. Christensen Professor of Orthodontics in the Department of Orthodontics and Orofacial Genetics at the Indiana University School of Dentistry. And Dr. Enid Neptune is a pulmonary critical care physician and Associate Professor of Genetic Medicine at Johns Hopkins University School of Medicine. Both of our speakers are members of the Foundation's Professional Advisory Board. Dr. Frazier Bowers, Dr. Neptune, thank you for joining us. We're delighted to have you. Please begin when you're ready.
Thank you very much. I'm going to go ahead and share my slides and hopefully doing this properly. Please advise if I'm not, if you can't see it or something is amiss. Is everything showing up?
I can see your slides. They're not yet in presentation view.
Okay. How about now?
Now they are. They're perfect.
Okay. Very good. Thank you so much and welcome everybody. Good afternoon, I think. This is global, so it may be different times, but I first want to thank the Marfan Foundation, especially Lauren May, who just spoke, who has had a tireless effort in getting us up to speed. I also want to thank Dr. Enid Neptune, who is going to be the presenter with me. It's truly an honor after knowing her so long, and you can see a picture that's more recent, that this is the first time experience that we've had to co-present. So I'm thrilled, and I thank you all for being here in attendance. Let's make sure my mouse is working here. Here we go. So I just want to give some very overarching objectives. We want participants to learn about the orofacial and dental and upper airway structures that interact with primarily Marfan, but we'll try to touch on a little bit of other connective tissue disorder patients. We want you to have a better understanding of the orofacial, dental, and upper respiratory diagnosis and management strategies. And we want you to be able to ask questions. There's a very important Q&A component to this talk where you can identify resources and appropriate management steps. I'm humbled and intimidated that I'm going first because Dr. Neptune is certainly going to blow us away, but I did decide that we would start from the top down, meaning the oral cavity in the mouth is kind of right before we get to the upper respiratory tract. And just to give a brief overview, the upper airway, sort of in lay terms, is a soft wall tube running from the nose to the voice box. And most of the tube, not necessarily the nose or the trachea, but most of this tube is soft walled. It doesn't have bony support, so it relies on musculature. So when we're awake, muscles keep it open, and when we sleep, they relax. So I'm not going to get too much into the details, but the nasopharynx is behind the nose, above the soft palate. The oropharynx is behind the mouth, behind the tongue and soft palate. And the tongue, especially the base of the tongue, if you're looking at the images, and I'll try to put on laser pointer. You can see the tongue sort of rests in the mandible or jaw, and potentially can be, it can potentially be a blockage to the airway. So we're going to focus on different structures in the oral cavity. You've heard probably just about as much as you'll hear about any other upper respiratory anatomy. I'm going to now focus on dental and other oral cavity. We want to frame this in the disorder in the way it's typically described. There's a musculoskeletal nosology, and where does dental fit in that? Dental, in terms of specifically Marfan, fits because often there's a presentation of a narrow face with a high arched palate, a downward turn eyes, and joint hypermobility. And I think we all know what the TM joint is, which is the joint that connects the mandible to the skull. That's what we think about when we think about the features in Marfan and some other connective tissue disorders. But what else is a consideration for dental treatment? Pre-medication is a big consideration, and I'll go over that a little more, but we're thinking about things like historically mitral valve prolapse, which according to the American Heart Institute and the American Dental Association is not something you need to pre-medicate for anymore for dental treatment, but other more major criteria, cardiovascular criteria, such as aortic root dilatation. So the Marfan condition is primarily what we'll talk about, but I am going to give at least one example of Loeys Dietz. And here you can see two characteristics that may or may not appear in affected individuals. One is a bifid uvula, which literally looks like two lobes, and a cleft palate, which is also a cleft in the palate, as you see. Well, why am I mentioning this in the context of talking about Marfan first? But I wanted to put a question in because one of the greatest resources for me to frame any talk is with questions that have been posed. One question came that says, what is the best course of action with severe enamel hypoplasia? And I won't read the whole thing, but first and foremost, the fact that this person knew what severe enamel hypoplasia really kind of blew me away. But I wanted to talk about this in the context of what's happening with a tooth. Most of us know that the tooth is sitting in a bony crypt, alveolar bone, particularly the roots, which are innervated in the middle, the pulp cavity and the root apices. And that is surrounded by dentin tissue and enamel tissue. The enamel is formed in a stage called the Bell stage. And the time that it's formed is the time where you could potentially have some disruptions with how the enamel presents, whether you have enamel hypoplasia or just thin enamel. Well, that question was frequently asked, and I fortunately did find a study that showed, in addition to having an abnormal palate in a cohort of about 38 patients, or 40 patients, excuse me, in addition to having the things that we already knew, abnormal palate and a retrognathic or mandible that's somewhat pushed back, they also found that you did have enamel defects. So for those people who have been asking, are there problems with the enamel of people with particularly Loeys Dietz, looking at the study done at the NIH intramural investigator, they did find there's a correlation. So that's not being imagined. Another question from someone who had VEDS. Considering having some dental surgery for a tooth implant, what do they need to know for the consult? What other advice can you provide? I put this slide in, not necessarily just focusing on VEDS, but what we know about, as I've alluded to earlier, the American Dental Association's recommendation is that only patients with severe, as determined by their cardiologists, conditions associated with their syndrome would need to be concerned about an adverse outcome from infective endocarditis. So otherwise, we don't recommend that we over-medicate people, because we don't want to, first of all, put people at risk of having antibiotics they don't need, and then having antibiotics that eventually won't work so well because they've been overused. But if it is determined by your cardiologist that you need it, and you are having a procedure such as dental implants, this is definitely a procedure that is very invasive. Thinking practically, a person who has Marfan, Loeys Dietz, or VEDS, you can have implants in terms of their success rate, but your consideration has to be that there's a long process from the time that you have this open sort of wound, 40 days literally, and this is mimicking an extraction, but it's similar when you get an implant. So that this is a very invasive procedure. And if you do have a cardiac condition as deemed by your cardiologist as requiring antibiotic prophylaxis, this is an indication to get it. More about Marfan syndrome. Many of the dental characteristics we see in the Marfan syndrome are common in the general population, such as overcrowded teeth. It is not uncommon to see, especially the upper jaw where it can be more narrow, have teeth that are very crowded. That narrow jaw actually creates something also called a posterior crossbite, not in all patients, but in several. A crossbite is when the upper teeth, instead of being on the outside, they're kind of on the inside of the lower teeth when you bite down. Due to its narrow size, the teeth are not interdigitated properly. This slide shows an example of someone. When we say vaulted, we literally mean it's deep, like a vault. And this is narrow. Of course, you don't have a frame of reference to look at something else, so it's probably not so easy to know what is typical. Oh, hold on a second, my pointer went away. Just a second. Let's see. Sorry, hold on here. Okay, my pointer's back. Sorry, this keeps happening. Here we go. Okay. When you have a crossbite, which appears as you see in the slide here, again, this is showing the upper teeth inside of the lower teeth. On this side, it's a little constricted, but it's a little more normal. You may be someone that could benefit from a palatal expander, and that's shown here. Why do we need to fix a crossbite? Why can't we just leave it like that? Especially in young children, it could reveal an underlying jaw problem, and it's best to do it when they're still young. It could also force you to shift your jaw to one side, which is not good in people with connective tissue disorders, because you may actually exacerbate any TM joint issues that you have. And it could cause lopsided growth. But to segue into Dr. Neptune's talk, would this contribute to the development of sleep apnea, the narrow palate? And I'm just going to say a little bit about that. Is the obstructive sleep apnea connected with palatal size and shape? Dr. Neptune is going to give a lot greater description of what constitutes obstructive sleep apnea and sleep disordered breathing. But the jury is not fully out yet if there is a direct correlation with the palatal size and shape. But what do we know in the general population? We know that in selected cases, rapid maxillary expansion, which you can see on the right side of your screen. You take a key and you crank it literally. In children who were treated with sleep disorder breathing treated because of sleep disorder breathing problems with expansion of both upper and lower, they did have a sleep improvement in 66% of the patient. There was also a reduction in their AHI. And the AHI refers to the hypopnea index, which is the number of times that your breathing stops or becomes too shallow. So there was some evidence that this helped. In some cases, people will use something called myofunctional orthodontics, which also moves or changes the position of your jaws using appliances. And we'll talk a little bit more about that. And there hasn't been enough evidence, however, that maxillary expansion will completely cure OSA or if it's a good therapy for snoring. It should only right now be done for patients who have constricted maxilla. So in other words, if you have a constricted or narrow maxilla, having it expanded should be done for that reason, not because you're going to cure OSA. This is an example of a functional appliance. And the studies that have been done have not always followed the correct diagnostic rubric. So it's not clear if there's enough evidence to say that using an appliance can actually manage or cure it in children. In adults, however, there's a little more evidence that this might be a good alternative. The oral appliance, it advances the mandible and protrudes and helps stabilize the mandible in order to maintain a patent airway. These are just examples of that. But what we know is that there is some correlation with mandibular size and the potential development of sleep apnea, but it's not an isolated, they're not isolated factors. Other factors such as age and obesity affect that. And I know in this population, that's typically not what we think about being diagnosed with obesity. Another study which uses literal screws that are screwed into the palate to help break this mid-palatal suture, it showed a success rate of 85% or 83%, and it did show some respiratory benefits as well as occlusal benefits so that it did correct the crossbite. It also showed that the AHI improved and did also improve snoring as well, or decrease snoring, I should say. Finally, in very severe cases, you can actually do a surgery that advances the upper and lower jaws. It's called maxillomandibular advancement. And you can look at the two pictures, the one on the left being before and the one on the right being after, where everything was brought forward. Overall, this is used in very severe cases, but I do want to add before we transition to Dr. Neptune that anytime you're thinking about any of these interventions, it has to be that you have worked in an interdisciplinary, interprofessional setting with a physician first that has diagnosed you. But once the diagnosis is made, a physician working in close agreement with an orthodontist can actually advise on whether some of the therapies such as the appliances and or the surgery would be indicated. And with that, I'm going to stop sharing so that Dr. Neptune can add her slides. And then we'll follow up for any questions.
Well, hello, everybody. I'm going to share my presentation with everyone. Let's see. Hmm, hmm, And let's see. I think. Okay. And I'm hoping you can see this.
We can see your full grid of slides. We don't see your there you go. Perfect.
Oh, great. So I'm so happy that you decided to attend this webinar, and it's an absolutely blissful experience for me to partner with Dr. Frazier Bowers, who is the best orthodontist that I know. And what I'm going to do today is I'm going to talk about specifically sleep disordered breathing and Marfan syndrome related disorders. And I have to admit, we have so much more data in Marfan syndrome than we do in other disorders. And that creates an opportunity for us to kind of invite more input from our patient population so that we can actually determine what the spectrum of sleep disordered breathing are for VEDS and for LDS, as well as for Stickler. I start with this slide because during the Q&A section, I want you to kind of feel comfortable asking me questions about all aspects of lung disease and Marfan syndrome and connective tissue disorders. But here I show kind of what the predominant symptoms are of my patients with Marfan syndrome who are referred to see me as a lung specialist. It's usually shortness of breath primarily or non-cardiac chest pain. And outside, we see kind of the whole spectrum of kind of the diagnoses that are associated with Marfan syndrome. They range from pneumothorax, the blebs, asthma, lung restriction, deconditioning, and finally sleep apnea. Now, on this slide, I provide a framework of how we think about shortness of breath in the context of Marfan syndrome. And obviously, the first thing we want to consider is, could there be a cardiac contribution? Is there something involving the heart? And we consider the valvular heart disease, we consider structural heart disease, cardiomyopathies, and obviously arrhythmias. But once those are ruled out, we have to invoke possible lung issues. And that's where the whole spectrum of these diagnoses and findings in our patients become very, very important. And those range from chest wall deformities, respiratory muscle weakness, enlarged air spaces, emphysema that can lead to pneumothorax. And occasionally we have to deal with asthma or pulmonary hypertension. But today I'm going to talk to you about sleep apnea syndrome. Now, I have deconditioning here because often our patient population suffer from deconditioning. And what we know is that with Marfan syndrome, reconditioning typically takes a much longer period of time than it does in populations without this disorder. And, Dr. Frazier covered this somewhat, and I want to emphasize when we talk about the respiratory compartments, we separate the upper respiratory tract from the lower respiratory tract. And the upper respiratory tract is the mouth going down to the trachea, as you see here. And the reason this is important is because the primary lesion in sleep apnea occurs in the upper respiratory tract, but the consequences that we see clinically are very much kind of experienced by the lower respiratory tract and the full body. So all of the considerations in terms of the anatomy that Dr. Frazier brought up are instrumental in how we understand the whole development of sleep apnea and the interventions that we use to treat it. On this slide, I wanted to kind of emphasize how directional airflow works, because some would say, oh, what's going on in the upper airway? How can that affect kind of what's going on in the lungs? But when you think about directional airflow, you need to recognize that when we take a breath in, it goes through the pharynx, and that's kind of the mouth and the upper airway. And then it goes down to the trachea, the bronchus, the bronchiole, and alveoli. And the alveoli are the terminal sacs where oxygen actually moves from the lung proper into the bloodstream so you can oxygenate all the critically important organs. But sleep disorder begins in the pharynx. And what this means is that once you obstruct airflow at that very, very upstream position, you compromise airflow going to all of these other compartments. And that is why it's such an important and serious issue to address. A point I want to make is that sleep apnea is vastly underdiagnosed in our Marfan population as well as in the general population. And the definition is the intermittent cessation of airflow at the nose and mouth during sleep. And we use the term sleep apnea often interchangeably with sleep disordered breathing. But when I say sleep disordered breathing, that also includes loud snoring or snoring. Now, it affects about 2% of middle-aged women, about 4% of middle-aged men. It can be the cause of excessive daytime sleepiness, and therefore we're very concerned in persons who have to drive long distances or persons who use machinery, etc. And we divide sleep apnea into obstructive or OSA versus central, which is CSA. The vast majority of patients with Marfan syndrome and sleep apnea have OSA. And what that means is that they can't breathe because there's a physical obstruction in their upper airway. With central sleep apnea, we call that won't breathe. And that means the stimulation, the neural circuits that tell you to breathe are just not working. Now, it's not often kind of discussed, but sleep apnea impacts the health and quality of life. And if you encounter persons before and after they've been treated for sleep apnea, they will tell you it has made the most substantial difference in the quality of their lives. It affects extreme fatigue, cognitive dysfunction, the ability to concentrate for long periods of time, and mood changes. I mean, it will affect the personal relationships, work productivity, and the overall engagement in one's life. But the long-term consequences are also substantial, especially for patients with Marfan syndrome. And those include what we call cardiac strain and the risk of arrhythmias. But we can also see metabolic impairments. There's a higher risk of diabetes. There's an increase in overall mortality. And recent data suggests that there may, in fact, be an increase in kind of cancer risks. Now, on this slide, we depict kind of precisely what happens with obstructive sleep apnea. As you can see here, with normal breathing, airflow is occurring through the nose and goes down to the lower airway, and also through the mouth, as you see here. And again, it goes down to the lower airway, and this is the tongue. When you have sleep apnea, you have basically a drop in the upper kind of palate that obstructs kind of nasal airflow, but you also have the tongue that falls back in the posterior of the throat, and that affects the airflow from the mouth. And that's why airflow is effectively blocked. How do we diagnose sleep apnea? Well, we typically do a sleep study. And historically, the sleep study is what we call an in-lab study, where we would bring you in to a clinic and you would stay overnight, and we would perform a whole battery of studies that include brain activity, eye movements, muscle activity, airflow, oxygen levels. And what we're really looking at is how deep you sleep and whether there's a drop in oxygen levels that are associated with these periods of apnea or low airflow. And with that, we are able to generate what we call an apnea-hypopnea index, and it's considered abnormal if it's greater than 5. We also measure kind of parameters such as sleep latency, how long it takes to fall asleep. People who tend to have sleep disordered breathing, they fall asleep very quickly. And sometimes we actually are able to measure upper airway resistance during sleep. On this slide, I'm showing kind of some of the tracings that we're able to generate with the sleep study. And what these tell us is the stage of sleep that our patient is in and whether they're awake. And by doing that, we can determine if there are frequent awakenings. Now, why would you be looking for awakenings? When you have an obstructive event, it triggers all sorts of chemical changes in your blood that forces you to wake up. So these awakenings are signatures of sleep apnea. And we also measure the airflow at the nose, we measure oxygen saturation, and we also measure the heart rate. Now, there were a few studies that were done historically looking at the prevalence of obstructive sleep apnea and Marfan syndrome. And again, these were done in relatively small populations, and they weren't done in the United States. And these studies showed anywhere from 32.5% to 64% of patients with Marfan syndrome having sleep apnea. And that was far in excess of control populations. And there was one study that actually showed a high prevalence of snoring. And what I'm going to show you is some of the data we have more contemporary, in a more contemporaneous fashion, that we were actually able to recover from a Marfan Foundation meeting and from our amazing population of patients that we see at Johns Hopkins. Now, one of the aspects of sleep apnea that we're especially concerned about is how does sleep apnea affect the aorta? Now, what we know is that with normal breathing, you have to generate kind of a negative pressure to take a breath in. So when you inhale, you generate negative pressure that pulls air down into your lungs. And the pressure is on the level of about -3 centimeters of water. Now, when you have inspiratory flow limitation, which is what we see with sleep apnea, you require a much greater negative intrathoracic pressure because your body is telling you to try to inhale. And so it's working to try to pull in more air. And when you have this level of negative thoracic pressure, the organs that interpret it are going to be the soft tissue organs in the chest. And that's where we get very, very concerned about the aorta, which is soft tissue, it's very delicate, and that it will have to interpret this type of mechanical injury. Now, this is kind of what we call the mechanistic paradigm that we are using to explain why obstructive sleep apnea could very well contribute to progression in aortic enlargement and lead to the concerning outcomes that we sometimes have to address. We think that the progression is enabled by these intrathoracic pressure changes that I showed you. Persons with sleep apnea also have a high prevalence of systemic hypertension, and that can also contribute to aortic enlargement. And lastly, there are many chemical signals of tissue injury that are worsened with obstructive sleep apnea. And we think that this serves as a trifecta that could contribute to aortic enlargement and progression, and ultimately to aortic rupture and dissection. But what this also tells us is that if we intervene to treat the sleep apnea, we may well be able to attenuate this progression and hopefully prevent the inevitable aortic rupture or aortic dissection with the rapid progression of aortic enlargement. We were so pleased at a Marfan Foundation meeting in Baltimore in 2014, where we actually enrolled persons who had Marfan syndrome and with a study in which they took a home sleep device back to their hotel rooms. And they also filled out questionnaires. And what we wanted to know is what is the prevalence of sleep apnea in our population? And we also wanted to know is which type of questionnaire instrument would be the most useful for us. And we showed that moderate to severe sleep apnea was actually 32% in our patient population. And this is a threshold that merits treatment even in the general population. And if we looked at all kind of sleep apnea, even mild, that was 71%. The vast majority of patients in our study had some degree of sleep apnea. And the snoring prevalence was extremely high at 81%. And we identified what's considered a stop bang questionnaire as being the most accurate. This was another study that we did in our cohort at Johns Hopkins. We were interested in whether high-risk sleep apnea was associated with aortic root diameter or aortic root dilatation. And we also looked at loud versus non-loud snores because we had a detection system where we could differentiate that. And surprisingly, we found that loud snorers had a similar increase in aortic root diameter as patients who have moderate to high risk sleep apnea. We also found that the dilatation rate was significantly higher in loud snorers and moderate high risk OSA. So what this revealed is that the symptom of loud snoring in our Marfan population needs to be taken seriously. And on this slide, I show the correlation between loud snoring breaths and aortic root diameter. And again, this suggests that there's this whole phenotype that had been under-examined of loud snoring as a particularly important one in our patient population. So how do we treat sleep apnea? Nasal CPAP is the standard treatment, and that's the delivery of positive pressure through the nose and mouth that basically stents open the airway. And sometimes we deliver supplemental oxygen with that. Now, if there's any difficulty with CPAP use with mask fitting, and our patient population often has to use what I recommend is 5 to 10 different masks before we determine that the masks are going to be a problem. Then we have to consider the devices that Dr. Frazier mentioned, such as mandibular advancement devices or oral appliances. Weight loss is not as important an intervention in our patient population. And drugs are only used if there's a strong central apnea component. And rarely do we do surgery except in pediatric cases where we see a huge level of redundancy in the upper airway. And this slide depicts exactly how CPAP works. As you can see, we have the mask that's delivering positive pressure. And in the untreated context, you can see the obstruction here. And once we deliver the positive pressure, you can see that the obstruction is kind of relieved significantly. And these are the devices that have been used. We can deliver the CPAP through a nasal mask, and these are for people who are not mouth breathers, or through a full face mask, as you see here. And we have a whole variety. There are hundreds of different masks that you can try. So you don't have to worry about exploring different masks in order to find an optimal fit. We have lots of them. And this is one of the dental devices that Dr. Frazier mentioned. I wanted to kind of quickly cover some of these other agents that have been advanced for use in sleep apnea. One of those, and I'm sure many of you have heard about these GLP-1 agents. And there is one GLP-1 agent, tirzepatide, that has been approved for those who have moderate to sleep apnea and elevated BMIs. Whether those medications would have any efficacy in our Marfan population is totally unclear. But the general thinking is that their efficacy is mainly through the weight loss kind of angle, as opposed to any direct effect on sleep apnea. There are also these Inspire devices that are advertised a lot on television late at night, in which kind of a little case is inserted beneath the chest wall, and there's an electrode that's introduced into the upper airway, and that stimulates kind of the breathing event. And these are for patients who have failed CPAP and have moderate to severe sleep apnea. But for our patients, there are real surgical concerns with those who have chest wall deformities. And there are many drugs that are underdeveloped, but none have been approved by the FDA as yet. And so I'll end with these two slides. Our studies have established a relationship between sleep apnea, intrathoracic stress, and vascular aortic injury. And what we hope to accomplish over the next few years are clear screening recommendations for Marfan syndrome, as well as related disorders, and to codify the treatment recommendations for mild OSA in persons with Marfan syndrome, because mild OSA is often not treated in the general population. But we definitely need more data about sleep disordered breathing for VEDS, LDS, and Stickler. And so my take-home message is that sleep apnea is highly prevalent in Marfan syndrome, but it remains underdiagnosed. And all adult persons with Marfan syndrome or related disorders should be considered for screening, especially if there are any sleep disturbances, including loud snoring or severe chest wall deformities. And an orthodontics referral should be explored for persons who carry this diagnosis and show oral facial impairments or are clearly intolerant of CPAP. And we have our Marfan Sleep Health Initiative at Johns Hopkins, and I will end there. And thank you for your attention.
Dr. Frazier Bowers, Dr. Neptune, thank you so much for your presentations. We've received a lot of great questions during that time, and it's a really good 50-50 mix, kind of. So I'll probably paddle back and forth with the two of you here. We'll go through those now. Let me just find my Q&A screen. There we go. This question is for Dr. Frazier Bowers. With VEDS and a history of gum recession, is it safe to do Invisalign, going slower and changing trays every 2 weeks to protect tissues? What are your thoughts?
So can everyone hear me fine?
You sound great.
Gum recession, again, this is another thing that happens in the general population, but the range of severity of gum recession is pretty broad. So without knowing how significant it is and what the age is, as we know, with age, a lot of things become more exaggerated. And if it is uncontrolled, meaning you've seen a periodontist, so I guess that's the first thing I would say. After you've seen your general dentist, if you want Invisalign or even traditional braces, if you have recession, we always have them followed by a periodontist. Is it safe? I guess the issue would be, is it any less safe for a person with VEDS than it is a person who doesn't have VEDS and also has the same condition? Because, again, the studies have not been as prolific in dentistry, the one that I showed did look at patients with Loeys Dietz. I think there were some VEDS patients in that group, but they are showing that there are differences, but there's not enough data to say that gum recession in particular is going to be so different than the normal population or the non-VEDS population. So I would just work closely with a periodontist, and any orthodontic movement when it's slow is better. So I will say that as a generality.
Great, thank you. Dr. Neptune, can you touch on a pneumothorax or a collapsed lung in Marfan syndrome? This person is saying that they've heard other people talk about it at conferences and amongst other community members, but they don't know how to recognize that, what symptoms to look for.
Oh, great. The first thing to know is that pneumothorax is one of the minor kind of findings for a Marfan syndrome. And we find that pneumothorax obviously is much more common in patients who have kind of Marfan syndrome that's punctuated by kind of blebs or overt emphysema. The challenge with pneumothorax is that in Marfan syndrome, they can be kind of what we call bilateral, so they can occur on both sides of the lungs, and they often tend to be recurrent. And I highly recommend that if you have recurrent pneumothoraces, that the intervention of choice should be what we call a mechanical pleurodesis, which is where you introduce kind of an area of scarring in the chest wall and the lung proper, almost like a Velcro strip, in order to kind of maintain the expansion of the lung. And the reason that that's preferred is that the alternative approach is to use like a talc pleurodesis, where you introduce an agent that can scar around the lungs in order to keep the lungs up. But in the event that you require aortic surgery in the future, that would be much more difficult for the surgeon to navigate. So pneumothorax, the bottom line, is more common in Marfan syndrome. The intervention should be more kind of focused and anchored on this idea that future aortic surgery may be needed. And if kind of there are any issues in terms of what should be done, how this should be monitored, how it should be followed, contact the Marfan Foundation, and then those of us who have a lot of experience with this issue would be able to weigh in.
Thank you. Dr. Frazier Bowers, this person says that their airway dentist and sleep medicine team is recommending the mini screw palate expander. They are hopeful but cautious, and they're asking, what are the considerations for someone with Stickler syndrome with a history of cleft palate, sleep apnea, and extremely restricted upper airway?
Okay. In general, I shared one slide on Marfie, and I'm assuming this is an adult.
You know what? It doesn't say, but we'll run with that assumption.
Yeah. So most likely, especially as it's associated with Stickler syndrome, we anticipate that the palate is going to be narrow. And as I mentioned in my talk, there are some studies that have shown an improvement in the AHI. I think it was respiration and maybe snoring. So if you're, and I tried to emphasize this, if your physician has diagnosed you and is supportive of a dental or craniofacial approach, then generally speaking, I would say that's a solid recommendation. There are people, there is such a newer kind of, I guess, specialty called sleep dental medicine. So there's like a subspecialist of practitioners who are dentists who have done some extra training in sleep medicine. And I would say a team of someone who is, sometimes they're orthodontists, sometimes they're not, but a team of someone who is your physician, maybe pulmonologist, the orthodontist, and someone who does sleep dental medicine. If they are recommending it, then I would say that would be a valid route to take.
Great, thank you. Dr. Neptune, hypermobile people can have a hard time moving their diaphragm, and then you add on top of that chest wall deformity from scoliosis, pectus, narrow chest wall, all of those things impacting breathing dynamics. Can conditioning overcome any of that?
Definitely. I mean, I am absolutely amazed at how effective a very dedicated kind of focused exercise program can increase exercise capacity despite kind of pulmonary function test numbers that look like the person should be significantly impaired. So, but what that requires is kind of an understanding of how to establish like a graded exercise program.
Right.
And in our current kind of universe, it's often very difficult to get referrals to kind of pulmonary rehabilitation or to kind of very standardized kind of rehab programs where you get the input from physical therapists, et cetera. But it's definitely valuable to have kind of a very strong kind of exercise program, especially aerobic exercise, because that is able to do amazing things.
Wonderful. Great advice. Thank you. Dr. Frazier Bowers, upper jaw deformities and crossbite were mentioned. Are there any special considerations for people with Stickler syndrome who have a recessed or underdeveloped lower jaw? And then this person says they also have moderate sleep apnea and have found double jaw surgery or some potential procedures for sleep apnea. So this is actually for both of you in some ways. Dr. Frazier Bowers, if you want to talk about the recessed or underdeveloped lower jaw.
There are a couple of things I didn't emphasize. There are people who have narrow palates who don't have sleep disordered breathing. And, you know, there are people who have Marfan, or maybe not. Stickler's is more known to have a narrow palate, but there are people with Marfan who don't have narrow palates. I've seen plenty of that. So you're kind of addressing two things. You're addressing the occlusal relationships, and in some cases, you're addressing the sleep disordered breathing. In someone with Stickler syndrome, where you have also the retrognathia, or the lower jaw that's receded, it is absolutely appropriate to look at, sorry, hold on. Okay, sorry. The lights go out if I don't move. It's absolutely appropriate to look, depending on how the physician has diagnosed your severity, at all of these interventions, which may include the surgery. But again, the surgery is for people who are on the most severe end of the spectrum. And I'll let Dr. Neptune jump in on that one.
Yeah, I think a diagnosis of sleep apnea, whenever I hear someone who says they have a diagnosis, I always ask, is it a diagnosis based on a valid sleep study versus is this a diagnosis based on like an Oura ring or some other type of wearable? Because to actually establish the diagnosis, a formal sleep study needs to be done. And the features and the impairments that are kind of described on that sleep study will dictate what type of intervention will be the most appropriate. So I think it's very, very important to have sleep specialists go through all the elements of the sleep study and basically explain where the points of intervention are. And I am totally happy to review sleep studies in our patient population and provide any kind of thoughts or guidance. So the message is Oura rings are nice, Fitbits are nice, wearables are nice, but you need to have valid sleep studies.
For sure, for sure. Thank you for driving that point home, Dr. Neptune. Dr. Frazier Bowers, have you dealt with patients who are dealing with teeth grinding or teeth clenching or TMJ and a connective tissue condition? And what's the recommendation there for management?
And so again, I was just joking a little bit with Dr. Neptune that we have so many specialists and subspecialists or super specialists. I am an orthodontist, which means I'm a dentist by original training, but most general dentists and many orthodontists don't specialize in TMD treatment. Again, there are people in dentistry who are TMD specialists, like we have one here at Indiana University. He's an oral surgeon. He not only does managing symptoms, but he actually will do total joint reconstruction. So my recommendation is once you have some diagnosis from your general dentist, to have them refer you to someone who treats TMD problems comprehensively. So someone like me, I might, if it's mild enough, I might give you a night guard or something, a splint, but really to get a comprehensive workup from someone who specializes in that is the best way to go. I hope, does that answer the question? Does it sound like I answered that?
I think so, yes. Thank you very much for that. I appreciate that. This is kind of a dual one as well. How do we communicate with surgeons and anesthesiologists about preserving our teeth, vocal cords, and airways before surgery? Personally, I have damaged vocal cords and have some swallowing issues after multiple surgeries. So how do you begin that?
I'll just weigh in.
Yeah.
But I'll extend that question to the whole idea of how do you kind of navigate kind of the surgical specialties when you have an underlying connective tissue disorder. And I think that you have to really use kind of those physicians who have expertise in your disorder. I mean, yes, you're able to advocate for yourself, but other physicians who know your disorder, know the risks, and are able to talk to surgeons and say, this is what our patient population experiences. These are the known risks of this particular procedure. And please be careful about this. I find that we have the most informed and engaged population of patients. I'm always amazed. But I invite them to use us, use the experts, the persons who see many, many patients with these disorders in order to interface with surgeons. And for the most part, the surgeons really, really appreciate it because the last thing they want is to possibly kind of perform a procedure that may not be kind of associated with a good outcome.
And I don't have a lot to add, but I will add that when you're going for any type of surgery, there's always supposed to be a hospital dental team there that's very cognizant of the impact on your oral health. And I don't know how they're deployed because I'm not one of the hospital dentists, but I would imagine that they're part of the team that decides what needs to happen before, during, and after surgery.
That's
So
great.
being an advocate is important. Sorry.
No, I'm sorry. I had no idea that a hospital dental team was in the mix. So there's
usually,
huge.
it may only be one or two hospital dentists in any given hospital. And I know just from being one of my colleagues and visiting a lot, they would be brought in on certain cases to say, oh, what should we do? They have dentures or like whatever's going on.
Sure.
But to be honest, I don't know how often that is deployed. I imagine, as Dr. Neptune said, you have to be an advocate and use the advocates at your fingertips through the Marfan Foundation, for instance, to help push that agenda.
Thank you. This person is saying their son has VEDS and is 6 years old. He does have a narrow, high-arched palate. Would a palate expander be contraindicated for him because of his VEDS diagnosis? They follow up by saying, I had a consult with the orthodontist. He said he would only consider doing it with periodontist following. So just they're curious if the risks outweigh the benefits.
So I have not heard. Again, there's a paucity of studies in many of the connective tissue disorders with dentistry specifically. I have not heard that there would be a contraindication. I think in general, it depends on the current health status of each patient. How are they manifesting their connective tissue disorder? At what extreme? As we all know, there's some people who have a significant feature and others that barely have any. So it depends on the patient. And that's why one of the standard things we say is before you start any type of dental procedure that's more invasive is to have the cardiologist consult. And but I don't think there are any limitations. I would love to, I'll share my email in the chat.
Wonderful.
Or do you? I'll share it in the chat.
That's great. Thank you.
Because I would like to investigate that a little more. So I think I just did that.
You did.
And they can contact me directly and I want to look at that. Is it showing up? Or?
Yeah.
It went into the hosts and panelists, but I'm going to put it in for everyone if that's okay.
Oh.
No, that's okay. It's out in the world now.
Okay. All right.
Okay. Thank you for that. We're at overtime. Are both of you still available or no?
I am supposed to be running to the clinic, but I'm sure a few more minutes would not be.
Okay.
Yeah.
Okay. You just tell me when, because the questions are great. Dr. Neptune, we have a few questions about blebs and the risk of flying on commercial aircraft with a large bleb that's maybe 5 to 7 centimeters. Is there anything that they can do before, during, or after the flight, or what's the best recommendation there?
The challenge with kind of monitoring blebs is that we have no ability to predict when and in what setting a bleb might kind of evolve into an actual pneumothorax. So I do not think the presence of a bleb should prevent someone from actually flying. What I would say is that if you have blebs and you've had a recent pneumothorax, we usually recommend that you wait at least 3 months from the actual event before you fly. And that is simply based on just anecdotal data. It's not based on any type of broad clinical trial. But the presence of blebs themselves really is not a contraindication to flying. It's not a contraindication to diving. It really is something that we need to be aware of because in the setting of a pneumothorax, we know what the predisposing kind of lung architecture is.
Great, thank you. Dr. Frazier Bowers, this person is an adult with LDS4 and they have significant thinning of the enamel resulting in ongoing issues with tooth hypersensitivity. Are there specific dental treatments or products that you recommend to slow down the progression of this problem and or mitigate the tooth hypersensitivity? It's hard to know what's real and what really works and what doesn't as a consumer.
Yeah, unfortunately, I'm probably going to talk more about how to mitigate in terms of slowing down something that the pathology of it has not been completely worked out. The little table I showed from one of the papers has shown that it is a real thing, but what is actually the full mechanism of why it's happening is a different story. But for just kind of mitigating, Sensodyne products are actually really good. And if we're definitely talking about a wearing down of enamel and not cementum, enamel, remember, is the hardest tissue in the body. The cementum is what's covering the root, and that's much softer. So some people kind of blend the two together when they start having recession, and their roots will become sensitive and they'll start to wear away. Two different things, but both should respond to Sensodyne. And depending on the nature of the enamel wear, you might be able to have some moderately conservative composite restorations that kind of, it's like a tooth colored filling that kind of helps cover everything.
Okay.
So that can be considered as well with a very good restorative dentist.
Right. I'm going to make this the last question. We do have a few more, but this is where we'll wrap things up. Dr. Neptune, we have a few questions about bronchiectasis and impact on the aorta. What are your recommendations there for managing that?
Bronchiectasis is a less common kind of lung manifestation for Marfan syndrome, these disorders. And there is a very extensive workup that we need to perform for bronchiectasis because there's a significant risk of infections that can be very challenging to treat. And there's also kind of a protocol for what we call airway hygiene, et cetera, that's important for kind of the best management of these patients. The overall recommendation in the context of the aorta are similar to those regarding the other kind of concerns with Marfan syndrome. And that is that it's important to kind of follow kind of the lung function and the pulmonary function testing. And it's also important to perform exercise testing to establish exercise capacity. So the finding of bronchiectasis basically says you need to be under the care of a pulmonologist, and ideally a pulmonologist who is willing to engage kind of the Marfan Foundation or physicians that have some expertise in Marfan syndrome. But in terms of direct effects on the aorta, there's nothing that we've seen kind of in the published literature or in my own experience that would make me concerned.
Okay. Many thanks to everyone who submitted questions, and especially to Dr. Frazier Bowers and Dr. Neptune for staying even longer and sharing their expertise and insights. If we were not able to get to your question today, staff in the Marfan Foundation's Help and Resource Center can assist with questions about your specific situation. Please visit marfan.org/ask, and a member of our team will be in touch. Again, thank you to our speakers and to all of you for joining us. Take care and enjoy the rest of the conference.
Thank you. My pleasure.
Thank you.